हम हम सभी जानते हैं कि जो बेसिक पब्लिक हेल्थ नॉलेज अगर हम यूजी में पढ़ा या फिर कम्युनिटी के साथ हमको अनुभव है कि मलेरिया इज नॉट ओनली अ डिसीज विच शुड बी फोकस्ड ओनली ऑन हॉस्पिटल मैनेजमेंट, रादर इट इज समथिंग दैट हैज टू बी टैकल्ड इन द कम्युनिटी. सो हम पिछले बार भी बात किए थे कि दिस इज अ को लर्निंग स्पेस एंड कोलैबोरेटिव लर्निंग स्पेस, इसलिए हम लोग we want that everyone share their experiences from the parts that they work with and the cases that they deal with and how they are managing malaria at their own individual level with their own community. So this week again we have joined together to discuss the management of malaria in community settings. Today we have the presence of many of friends and people who have been working in various parts of the country with not only malaria but also with various other diseases, and they have been managing this disease in the community. And we are in gratitude of them that we are going to learn from each of them from their individual stories. So thank you for everyone for being there today for this session. And also the many of the friends are going to join in, but we will start the session considering the time. uh, Today we have already started the recording of the session, but I have also requested a friend, Jannavi, to record the session in writing as well. This summary shall be shared in the social media groups and the people who have not attended the session, and the video of this session will be uploaded on YouTube. Uh, for all the other members who have participated, they can share their questions or opinions in the chat box as well, which can be taken up later. So with that, I invite Dr. Anuj Mundra, sir. Dr. Anuj Mundra is associate professor in Department of Community Medicine at MGIMS Sevagram. I invite him to share the experience of malaria and especially on integrated vector management and what are the current practices at the systems level.
Yeah, thank you, Srinidhi. And good evening to everybody present here. And I must say, this is a privilege. I've not been part of so many such informal groups, and again, it feels nice to get connected to this thing. So, again, as I understand that time would be a factor for us, so I would keep it short. And as Srinidhi has already informed you all, I work as a faculty in the Department of Medicine at Mahatma Gandhi Institute of Medical Sciences here in
I think
Singapore.
there's still some drinks out there. Let's go get some.
So, when I talked to Srinidhi regarding this community-based management of malaria, the first thing that came to my mind is, unlike the earlier decades when uh, community-based management was being practiced and case management was also happening at the community level earlier when we used to give as an empirical therapy for to fever cases. So that was one part, and now we have moved ahead. We are moving towards elimination of malaria, and so now we no longer prefer giving empirical therapy of chloroquine. As you all must be aware about the drug resistance, and that was one reason why that happened. Then after that, there is fever management at the community level. So we thought that okay, we shall discuss about what is being done at the programmatic level, a bit about the history of how has the National Vector-Borne Disease Control Program and malaria control activities evolved over time. Okay, sorry. So is it fine now?
Yes, sir. Yes.
So, yeah, so the way it has, so we thought that we would discuss about how it has evolved and maybe in brief about, community-based activities or maybe for that matter, prevention of other vector-borne diseases. So yeah, I'll just start sharing my slide. Srinidhi, can I get the access to,
Yes, sir.
share?
I will make you the host, sir. Sure. Sir, you can share the screen.
Yeah, thank you.
The
Is
screen
that?
is visible, sir.
Yeah, thank you. So, yeah. Just- So, we know that malaria was, when Ronald Ross was working on malaria. So then we knew that, so that was a time in the late 19th century that we came to know about malaria. But then Anopheles and Plasmodium have been existing since long, and phylogenetic and the genetic studies they have informed us that Anopheles has been living since about 100 million years. So once we got to know about malaria, we got to know about the parasite, the vector. So then there was some research, and initially malaria control was focused on use of Paris green and mineral oils in the early 20th century. And then we again came to know about some other insecticides, the pyrethrum extracts, DDT, etc. Uh, Talking about the malaria control in India, so prior to independence, there was no organized malaria control program at the country level. There were isolated uh, control measures being taken out, and National Institute of Malaria was the apex institute which was looking after that, and that institute was established somewhere around 1970s, 1930s. So in 1953, it was the first time that India had a malaria control program, which was named as National Malaria Control Program. At that time, India had a huge burden of 75 million, approximately 7.5 crore cases and around 10 lakh deaths. So the earlier part, the National Malaria Control Program focused mainly on indoor residual spray through DDT, with using DDT, and a bit on the case management. It was a bit successful. Coming to 5 years on, 1958, India launched the National Malaria Eradication Program. And then eradication program there, the surveillance was intensified. There was house-to-house surveillance. We moved on to better case management, better surveillance strategies, which led to us reducing the case burden to approximately around 50,000 in the early 1960s. And that's when things started to go, haywire. India was a relatively younger country. There were a lot of other priorities. India was engaged in a couple of wars with Pakistan, China. There were a lot of development process going on around the country. So the program became complacent, thinking, okay, we have controlled malaria. There were a lot of other priorities. Also, there was a lot of crop failure in the early 60s. So those were the competing priorities, and controlling malaria looked, very likely. So the program got complacent. The resources were mobilized to some other areas, which led to a resurgence in the late 60s and the early 70s. Also, during that time, it was understood that uh, malaria in some areas of South India, there were studies which told us that around 80% of cases in those areas at that time were being contributed from the urban areas, which led to the launch of urban malaria scheme. And gradually in 1976, India recorded the highest post-independence surge in the malaria cases after the launch of the National Malaria Control Program. And that's when India launched the modified plan of operations. However, we'll see what was there in this modified plan of operations in the subsequent slides. But then it was not very successful, and a period from around 1.5 decades, from 80s to mid 90s, there was not much improvement in the incidence of malaria. So then there was a modified action plan, and the enhanced malaria control project was launched. During this period in 1971, I'm also covering some other programs here. So in 1970s, the filariasis control program came into existence. In the late 1990s, the Kala Azar control program came into existence. Again, at the same time, the National Malaria Control Program, Eradication Program was renamed as National Anti-Malaria Program, because it was at that time that we understood that the strategies for eradication, the level at which the cases were still prevalent, the incidence was still high. So we could not have gone, for the eradication level activities. We needed to first control it, first eliminate it as a public health problem, first control it, and then probably we can move towards eradication. So it was not feasible to keep on the eradication activities. So we moved towards, again, the name was changed, National Anti-Malaria Program. And it was at this time that other vector-borne diseases were starting to integrate into this. So this under this National Anti-Malaria Program, the dengue and this Japanese encephalitis. So support was provided from this anti-malaria program during the outbreaks of these conditions. But overall, these conditions were not till that time. It was not under the ambit of this national anti-malaria program. It was only in 2002, 2003 that the National Vector-Borne Disease Control Program was launched, and at that time there were five diseases. Chikungunya was still not there under the ambit of National Vector-Borne Disease Control Program. Chikungunya came into this program in 2006, where there was a country where there was a big outbreak in 2006. So after that, chikungunya was brought whole and soul under this program. During this period also, we had these rapid diagnostic kits. So initially we had these monovalent kits, and after some years we had these bivalent kits also. And in these rapid diagnostic kits were provided at the community level with the ASHA workers at the PHC level, so that in areas where we do not have early access to microscopy, these can be used so that we do not delay the start in treatment, we do not delay the diagnosis of malaria. And even along with diagnosis, we do not delay identification of about which type of malaria is there. In 2006, we also had ACT, the artemisinin-based therapies were introduced. Prior to that, it was mainly dependent on chloroquine. So, in 1982, India first launched the first anti-malaria drug policy was launched when sulfadoxine pyrimethamine was introduced in areas where chloroquine resistance was found. And after this, there were a few modifications, few changes in the anti-malaria drug policy. And gradually, when we started to learn that the resistance is increasing day by day, so we'll see in later slides that there were much more frequent changes towards the first decade of the 21st century in this drug policy. And then after that, after once ACT was introduced, gradually what was also introduced in this NVBDCP was the distribution of long-lasting insecticide nets was used in endemic areas. And again, there was a big you may say a landmark in this program when monotherapy of oral artemisinins was banned in India. And we'll also see this was also a crucial step in some of our neighbors who have eliminated malaria. So they also had this similar kind of policy. So yeah, this was this, and in 2013, as I said, the this bivalent kits were introduced in the system. So, talking about some of the earlier initiatives in malaria control program. So, as I talked in under the National Malaria Control Program, the main focus was indoor residual spray using DDT. There was surveillance, but it was mostly passive surveillance, and then it was monitoring and management of cases. Under the eradication program, the vector control and surveillance became much more intensive. House to house surveillance was there, and there were mass surveys which were there for case finding. Under the modified plan of operations, it was then that we started to categorize the risk areas based on the APIs, that is the annual parasite index. And this is one of the most important indicators which is used to monitor the progress under the NVBDCP for malaria particularly. And this was focused in areas with high endemicity, and this also led to introduction of village health guides to support the surveillance and treatment of malaria cases. One notable achievement in under this modified plan of operations was that over 1.25 lakhs fever depots and drug distribution centers were set up across the country. So these depots, those depots were one of the major achievements there, and they continued to find, diagnose, and manage cases of malaria. Then came the Enhanced Malaria Control Project, where they further talked about decentralization. They talked much more about the community participation than it was prior to that. Insecticide-treated nets and long-lasting insecticide-treated nets were introduced. The promotion of environmental modification and biological control per se, using those Gambusia fish and other fishes, larvicidal, larvivorous fishes, that was started under this enhanced malaria control project. Eventually, we are in a phase where we are implementing the intensified malaria control thing. So just in brief, we have talked about how the program has progressed. This is just to show you how the cases have gone over a period of time. So you can see the the green bar here, the green lines. So these green lines, they show us the cases, and the pink ones show us the death. So there's some so as we can see here, in the early 1960s, the cases were very less, less than 0.1 million. It was just around 50,000 in 62, 63. Gradually, as we talked, the cases started to increase. It was here in early 1970s that urban malaria scheme was implemented in this 1976, where we reached this peak of over 6 million cases, over 60 lakh cases, and gradually it reduced. And then we again talked that in between 1980s to mid 90s, the cases were more or less similar. But there was one thing that again I was noting while I saw this graph, is that every few years the cases go up once, they go down for another 2, 3, 4 years, they again rise for a couple of years, and they're again going down. So we can see this trend after this point very specifically after 97. 2 to 3 years it is going down, it comes up, again goes down, comes up, again goes down. So we are now at a level when the number of cases have again gone down a lot. The number of deaths have also reduced a lot. So we'll see the achievements in further slides. So this is still 2020. This figure is just to differentiate between the urban and rural cases. So earlier, by 2005, you can see there was a lot of gap between the urban and rural cases. But now in 2020, 21, around here, the number of cases have gone down a lot in the rural areas, but urban areas have not made much progress in this the number of cases. One of the main reasons being the shortage of trained workers in urban areas. More and more developmental projects coming up, which are giving ample vector breeding sites in these urban areas. And again, earlier when the urban malaria scheme came up, so then it was understood why, prior to that, it was like it was understood that okay, malaria is mainly a disease of rural areas, but then it was understood that no, malaria is there existing in urban areas also. But alas, the program has not been able to cope up with the demands of the with the demands of controlling the urban malaria, which is evident here in the number of cases, which is not going down since around 1.5 decades. It is still there. Uh, Opposite to that, we have been able to reduce a lot of malaria deaths in urban areas. It's the same has happened in rural areas also, but almost the deaths are now almost negligible in urban areas.
So, Doctor, why don't you discuss even post 2021, because that is the
Oh, yeah.
context for the discussion.
Coming to that, yeah.
Sorry, Doctor. Why
Yeah.
don't you also discuss beyond 2021? Because there is data till 2026 also.
Yes,
Because
sir.
that is there is a trend that is differed from what you are discussing. So
Yes.
why don't you also discuss that? Would
Yeah.
you? Would
So,
you?
yeah, I don't have the graph for that, but I do have the numbers. So, what has happened again, as I was telling prior to this, is that the number of cases are increase after every 2 to 3 years. We see that this is increasing. That is exactly what sir is also talking about, I think, and that is exactly what has happened after 21. So, in 22, India had around 1.76 lakh cases, but starkly in 2023. the number of cases went up to 2.5 lakhs, and it has persisted in between 2.5 to 2.3, 2.2 lakhs for the next 3 years till 25. And for 26, till the month of June, we have already had 70,000 cases of malaria at a point when the high endemic, the season for malaria has not yet come. So the data is still for till I had the data till June. So till June we had 70,000 cases. So definitely we are going to add many more cases, and still this is again going up. We are again getting complacent. So I remember a few years back, we were sitting in our hospital and we were talking about fever OPDs to be started. And one of our professors told that I've hardly seen any malaria case in the last 2, 3 days. I've hardly admitted any malaria case. And again, we are also implementing one project with ICMR on vector-borne diseases. So at that time, at the district level, we went and we found that there were only 2 or 3 cases of malaria which were reported. So I'll come back to, if I may, I will just slide from. Yeah. So this slide. So this was published on World Malaria Day last year, 25. What has happened is that, again, yes, the government is showing that we have had an 80% decline between 2015. This is a typo, 25 to 23. It is just 2015 to 23. So yes, India has had a decline. India has had a big decline. But then in recent years, again, we are failing to, reduce the number of cases again. And there's another WHO's initiative, high burden, high impact strategies. India was a part of this group, but seeing at the decline in cases, India exited this group in 2024. So this high burden, high impact initiatives were being implemented in 4 states of India, but it is no more because India has exited this group. The number of deaths have also declined by 80% between 2015 and 23. In 23, around 122 districts have reported zero malaria cases. So we'll also discuss, we'll see how the districts are classified under this national this NVBDCP for malaria. So we have this test, treat, and track strategy, but I'm not very sure how much of the track is happening at the field level. And yes, again, India aims to achieve zero indigenous cases by 27 for achieving the target of 11 to 2030. So not going into the details of this drug policy, just to show the number of times this drug policy has been revised. So from 82, the next it happened in 95, 2002, 2004, and as I said, the frequency was a lot more in the early part of the 21st century because we were getting to know about new resistances, new evidence was coming up. And so we have had, 5 revisions in just 8 years from 2005 to 2013. I'm not aware about any further revisions. If there may be any further revisions, I beg your pardon for my ignorance. But to the best of my knowledge, 2013 or 2014 was the last revision. So then coming to the vectors, India has there are around 9 to 10 Anopheles species. The most predominant ones in India are Culicifaciens, Stephensii, and Fluviatilis. So Culicifaciens is the major culprit in the rural areas, and Stephensii in the urban areas. Fluviatilis in the foothills of Himalayas or foothills of mountains. Others are found, but they are very less in numbers. So these species differ, and not only these species, when we're talking about vector-borne diseases, many a times we talk about integrated vector management. So integrated vector management is fine, but then we also need to understand the behaviors of different types of vector-borne disease. The vector of malaria behaves entirely different from the vector of dengue, and the vector of lymphatic filariasis is also different from dengue. So these differ. And when we're talking about control of vector-borne diseases, along with integrated vector management, we also need to understand what is the type of vector-borne disease which is much more prevalent in our area, which is the major concern in that area, and maybe focus more on what messages we are giving, which are tailored to that predominant vector-borne diseases. So I will also talk briefly about that part later on. So again, this is something that you all must be knowing since we have discussed the clinical this one. So just to reiterate that we have now monovalent and bivalent RDTs. Still, microscopy is being done under the program, but in areas where microscopy is may get delayed, we have these RDTs, monovalents and the bivalent RDTs. So bivalent, we don't have any problem. We get both the results, but in monovalent RDTs, we can detect only falciparum and only if the risk of falciparum is less. That is the only condition where we give chloroquine, suspecting that okay, falciparum risk is low. We can suspect vivax malaria and then we can give chloroquine. But over a period of time, again, this slide was with from the 2013-14 drug policy. With time, availability of microscopy and RDTs have again improved, but yes, still is not at a level which we all would want to. So what I talked about the high impact, high burden, high impact approach. So this approach they were more reliant on the decentralized approach. They talked about districts to make their own specific approaches, plans to get their own decide their own budgets. Again, since this was not being implemented in the area where I am working, I'm not
माझ्यावाला
working.
कंच होतं हे नाही वाजवत. एक दीड तास वाजवला काय नुसती घाई नायगावला जायचं नाही पैसे तर घेतील वाजवत पण नव्हतं चांगलं.
So I'm not very sure how nicely was this implemented. And as I talked before, India exited this in 2024 because of the decline in the number of cases. So coming to after 2015, there was this global target for elimination of malaria. So India was also part of that, and India also agreed to be part of this. And in accordance, India had sorry, this is a mistake. The National Framework for Malaria Elimination 2017 to 2030. 2015 to 2030 it is actually, but this was made in 2017. India agreed to try and eliminate malaria by in 2015 India agreed to do that. So the vision was to eliminate malaria nationally and contribute to improved health quality and alleviation of poverty. The goal, zero indigenous cases by 2030 throughout the country, and maintaining malaria free status where the transmission has been interrupted, and preventing the reintroduction of malaria. So the objectives here, we will be discussing about some categories which is there in the upcoming slides. So maybe I can take you through those categories first. So under this, in the year 2017, the districts and states in India were classified into different categories. So there were four categories. Category zero was, I should start with category three. So category three was where we needed intensified control. In those states, the API, the annual parasite index, was more than 1 per 1,000 population at risk. And there were around 10 states and union territories in this category in 2017. Then there was category two, it was the pre-elimination phase where the state overall had an API of less than 1, but some of the districts had API of more than 1. So there were 11 states in this. Then in category 1, there were 15 states, and the states overall, as well as the districts in the states, all of them were reporting an API of less than 1 per thousand. And then there was category 0 in those states or UTs where there was no indigenous case of malaria. So there was no state at that time in 2017 which was there in category 0, but yes, there were some districts. So in this, so the previous slide talked about the number of states. This slide talks about the number of districts. So as you can see, in 2017, we had 75 districts in category 0. That means there were no cases of malaria being reported. 2019, 179, sorry, no, not no cases, but the local zero indigenous cases. So then in 2019, the number of districts increased to 179. Again, sorry, I don't have any further classification of this. I could not find. There must be this classification with the ministry, but it is not there on the websites or anywhere I could find. So this was the latest that I could get. So 2019, we had 179 districts in category 0. And we can see here in category 3, that is the areas where the states as well as those districts are having API of more than one. So there were 109 districts with API of more than one. And in 2019 itself, after the launch of this national malaria elimination framework, following which we had this national strategic program from 2017 to 2025. So as soon as the national strategic program was started to get implemented, so we could see a decline in the number of cases. We could see a decline in the districts having an API of one. So again, yeah, there was a lot of good progress that has happened during that time, which is evident in these numbers. We'll again come back to this. So the objectives of this national
Excuse me, sir.
yeah,
Sir, just a time check, sir. Can you
yeah.
please take 1 or 2 minutes more? Thank you.
Okay, so I'm sorry. ये ज़्यादा हो गया था थोड़ा सा. So okay, yeah, I'll skip this. Just looking at the graph. So there are still, this is more prevalent in the border areas of Chhattisgarh, Odisha and Maharashtra, Gadchiroli and these areas. And Gadchiroli is the only district now which has a high API in Maharashtra, and some of these northeastern states. So again, India has those six high burden states, which include some Tripura, Mizoram, Odisha, Tripura, Mizoram, Odisha, and some other state, Manipur again from this, yeah. Mizoram is a state which still has an API of more than seven in India. Other states are between one and two at the maximum. So yeah, these are the basic interventions. So intensified control phase, so these again, some of these are yeah. So I'll go to this pre-elimination and elimination, considering the time this thing. So in elimination phase, what we need to do is interrupting local transmission in all active foci. So we need to have those foci based surveillance and all these activities. One thing is the case-based surveillance, which we have moved in measles from those aggregate surveillance to case-based surveillance and management. So this is what needs to be done in elimination phase in all the districts which have achieved elimination. And all these activities must be continued hand in hand, must go parallelly in the districts in which phase they are. In the district which have achieved, which are in the pre-elimination or elimination frame phase, the intensified control phase activities, when they were achieved, they should not be, they need to be sustained. And there needs to be a quality assurance mechanism, epidemic forecasting. Yeah, so prevention of re-establishment is fine. So there are multiple challenges. We are aware of some. I would just like to take you to some lessons from Sri Lanka, which has eliminated malaria in 22. So they had these both active and passive surveillance, active surveillance through mobile malaria clinics, and there were a lot of civil unrest areas in Sri Lanka. So they acted in those areas, and in an era when we listen that okay, ambulance take 2 3 hours, but Zepto, Blinkit, and all these, they guarantee the pizza is being guaranteed in half an hour. Sri Lanka took a guarantee that they will deliver drugs within 1 hour, because private sector did not have these medicines. There was only in the government sector. It was done by law, and the government guaranteed, and they gave medicines within 1 hour to any case which is notified from the private sector also. Anyways, the private sector was not very strong in Sri Lanka. They had a case-based management, and follow-up microscopy was also done till 1 year of diagnosis of malaria. And even 14-day primaquine therapy was being given as a supervised treatment. There was a lot of good surveillance. They had very good entomological surveillance, vector surveillance. They used to identify vectors, the vector habits, and they had a good collaboration with armed forces, since there was a lot of civil unrest areas. And then they had this foci-based, case-based. Any case getting detected, so there was this reactive case surveillance. Any case getting detected, every resident within a radius of 1 kilometer, they were getting tracked, and they were screened for malaria within a period of 48 to 72 hours. So just coming to dengue, uh, the problem here is one thing which is I would like to bring your notice to is reliable water supply. That is one very important thing. हम लोग डेंगी वी टॉक अबाउट द डेंगी, हम लोग जब घर में पानी स्टोर करते हैं सो उनसे उससे होता है. व्हाई डू वी नीड टू डू दैट? बिकॉज वाटर नहीं है. हम लोग कुछ भी कर लें, जब तक रिलायबल वाटर सप्लाई नहीं होगा, sorry, I'm talking in Hindi. So till the time reliable water supply is not there, we will keep storing water, and this dengue will go on, affecting us, because there will be gaps in how we store water. So the vector will, breed there. So that is something that needs to be taken care by the government. Until and unless that is done, dengue will be there. Again, when I was talking about different habits of vectors, dengue is a day biter. So all, everything that we talk for malaria or filaria will not apply to dengue. If we tell people to use bed nets, probably we need to have some thoughts about what needs to be done during the daytime. So wearing full sleeves clothes is an option. So we need to customize what we are talking about, which disease we are talking about. MDA is being done for filariasis, and we again have a target of eliminating filariasis. We India introduced MDA from 2004, and it was told that 5 years of MDA, and then we will have this transmission assessment survey. India started this in 220 odd districts, and now it has come down to 100 districts. The rest have been cleared in the transmission assessment surveys. But yes, what we had envisaged we would achieve by MDA has not been done. It has been 20 years, and still only half of the districts have gone down. Kala Azar, it was endemic in a lot of blocks, 54 districts around. But the good news here is that by the end of 2023, it is no more endemic. Yes, it has not been, sorry, yeah, it has been eliminated by 2023. We are sustaining it. Maybe in a year or two, India will initiate the process to, apply for Kala Azar elimination certificate. Yeah, so that's all from my side. Sorry for making it a bit long.
Thank you so much for your insightful session, sir. I think the questions are in the chat box, but they have to be taken at the end, considering that number of participants are yet to share. Uh,
Okay.
Next up, we have Dr. Prakash, who is a part of Transdisciplinary Health Sciences and Technology at Bangalore. Dr. Prakash has come from a very rich background where they are into active research and implementing community research and outreach programs at TDU. And they have worked in the field of malaria as well as other diseases, integrating local health traditions and making scientific research out of it. So I invite Dr. Prakash to join the session and unmute. Thank you so much.
Yeah, thank you. Thank you, Dr. Srinidhi. Can you please enable me to share my slides?
Yes, sir.
Yeah. Yeah. Namaste and good evening to all of you. I'm traveling. I've had some other work also. I'm traveling this week, so I'm little occupied with other things. And I came to know about this
I have
wonderful.
made you co-host, sir.
Thank you. Yeah. So yeah, I'm trying to share the slide now. I think you are able to see it now.
Yes, sir.
Okay. Yeah. So as I mentioned, like say, yeah, I came to know about this committee, this meeting on this, and I'm very happy to be part of this. And thanks for Dr. Srinidhi for this opportunity. So sorry for the background noise. Actually, I'm traveling and I'm a bit in the middle, so there's a lot of background noise. If anything disturbing, please let me know. I'll make it. Yes, I'm going to make it very, very short. As Dr. Srinidhi informed me about 5 to 8 minutes, I'll try to do it. I know the group is a lot of discussion is going on and more on the community aspects of malaria management, I can say. So in this regard, as Dr. Suniti mentioned, I am from Transdisciplinary University from Bangalore. Some of you might not be aware of this university. It is basically to work on various aspects of Ayurveda and biology. So concerning about the Ayurveda and biology, we work on various aspects of looking at how traditional medicine can contribute for healthcare, specifically primary healthcare. And as a total, I can say how traditional medicine, which we are talking today, we are talking how it is can contribute. One of the very long-term studies which we are doing in the field of malaria is basically looking how traditional medicine can contribute to malaria. In that specifically, I'm going to talk about next 8 minutes about how malaria prophylaxis can be used, where how herbal herbs can contribute to this area. We have done an extensive research in this field to looking at like how communities are enabling the local factors. For example, let's say they're involving the local traditional healers, are engaging the local NGOs or CBOs, how they are integrating and working together as a part of the understanding, and also contributing to how to solve this local, global problem with the local knowledge and all. So in this area, I'm going to talk about that. Is that my slides are visible?
Yes, sir.
Yes.
Yes.
Okay. Okay. So in this regard, we work on Ayurveda biology, as I mentioned. So we take the examples of any traditional medicine and looking at how biology, how research can contribute at the level of preclinical studies as well as clinical studies. So in that regard, I'm going to share about like how traditional medicine. Of course, this is a very basic slide. I'm very sorry for this, but even as I was traveling, I could not access my mobile, so I'm just my laptop. So I'm just using others' laptop and making about 5-6 slides, very small, short slides to share quickly. I'm very happy to take any other discussions also in the next meeting or something. So as we know, the traditional medicine is a very vast area where we know about the Global Traditional Medicine Center and all. So considering that, you can see about 179 countries across the globe where we are using traditional medicine, one of the other forms of traditional medicines in the form of herbal medicine, naturopathy, or even chiropractic, or even acupuncture and all. So when we look into the traditional medicine aspects of people, how they are using, of course, we know that 60 to 80% of the people throughout the world, people are still depend on the traditional medicine, which is also accepted in various aspects of global reports and all. We can see where we can see traditional medicine is so, and even the traditional healers, traditional healthcare providers are contributing the factors within health system or the healthcare itself. So considering this, when you look at the Indian community specifically, which our university is very working on since almost about 30 years. So in this university, we understand that in Indian medical health, there are two broad sectors, I can say. So the one type of codified system of knowledge where we're all very familiar about the Ayush system of practice, Ayurveda, Yoga, Siddha, Unani system of medicine. But the other stream also about non-codified, which is very and common, and also we can see at the village level, at the community level, where people are having some knowledge on local resources, local medicinal plants, and they are non-codified. Their knowledge is transferred from generation to generation, from people to people, oral healthcare, traditional knowledge, and how they are contributing to the health system or the health practices concerned. So I'm going to talk about non-codified healthcare practitioners, who healthcare providers, who provides traditional medicines across the various aspects. I'm just putting some of them just to give a glimpse about what are the kinds of practices India has about since many years. So we have working about last 25 years about how to strengthen this network, and we understand the challenges with these systems also. Today we talk about quack. Today we talk about the various challenges and the hierarchy about the local health practitioners, this, and also about the Ayurveda practitioners and other systems of practitioners. So we are working with how the network of these traditional healers, and also they have very vast knowledge of local resources. And we all know like many medicinal plants are contributed for the modern medicine also to contribute in various aspects, starting from even quinine to Artemisia annua. There are many traditional knowledge which is contributed in some of the other ways of giving a leads to the antimalarials or in many other drugs. So in these components, we can see their traditional birth attendants, traditional bone setters, the various aspects of traditional healers. So our idea was to look at like how these traditional healers are contributing for this primary healthcare, especially in some of the areas like let's say Orissa, Chhattisgarh, and all. And we are based in Bangalore, so we work with the local NGOs in Andhra Pradesh, Orissa, and Chhattisgarh about last 50 years back. So where we identified some of the healers, some of the group of healers, they're providing traditional medicines for malaria management, in the sense both prophylaxis as well as treatment also. We were very curious to know about how these traditional medicines, how these healers are so much confident in providing these traditional medicines. So of course, this is a very fact we all know, and Raju also presented very nicely about all the things. I'll skip this slide, but only just to give a very demographic understanding. About 58% of malaria deaths occurs in a very low economic class of the people. That's a very surprising, and also very difficult to understand the point. And of course, we all very familiar about the different control strategies. I will not go into the details. Of course, many of you definitely familiar with about the physical method, biological, and these methods. But social participation is a very important in all these things. So what, and also about this life cycle is concerned, I'll not go into the details. Of course, we are very familiar, but just to highlight the two things here, we have a causal prophylaxis. Today we have a very wonderful causal prophylaxis, drugs and all, what in the previous presentation some of the drugs I mentioned, the liver stage drugs and the blood stage drugs. So where we are looking the malaria prophylaxis as well as the how we can manage malaria in these two aspects, terminal prophylaxis and supportive prophylaxis. So this is the very specific stage where our group has done a lot of work, anti-liver stage drugs involving herbal medicines. That is the work which I'm going to talk about in next 5 minutes. So looking at the existing current practices, of course, there are several medicines starting from quinine to chloroquine to other drugs. There are a lot of challenges with the resistance problems, safety issues, affordability issues, accessibility issues. These are all the very common which you can see in remote areas where you're all working. Many of you are working in the very remote areas. And when we started working in 2012, 13, 14, we observed that even though we talk about Pramipin is low, easily available, easily accessible, but still challenges to reach those nearby health centers, challenges in accessibility of those kind of practices. So what are the other alternative approaches? Traditional medicine is one we thought to, it can give some knowledge, some understanding about these practices. This is a one study which we did in Orissa, basically to document what are the kinds of practices people are doing in the community to understand. What we observed in some of these areas in Koraput district and Cuttack region, Mayurbhanj region, where traditional healers, a group of traditional healers, they have their own knowledge of medicinal plants, and they claim that if you take a kind of a decoction of medicinal plants before the onset of monsoon, when they are healthy, and they claim that they don't get malaria at all. It's a very small pocket, small communities, healers communities, but they have a kashaya camps, kind of a camps, where they distribute the kashayas, the decoctions prepared out of some of these medicinal plants. And their community, they say that we are not getting malaria, we are protected. So this was the very first time. We also very surprised to see like how they can claim these kinds of practices. So we documented some of these practices and started working on what are the models to evaluate those kinds of things. What are the other things? As I mentioned, like we use the liver stage specific models. That is about in the year of 2012 to 15 years where we didn't have the specific model. We've collaborated with Indian Institute of Science, NIMR, National Institute of Malaria Research in Bangalore and all. Then started working on how to screen these medicinal plants and do we get any kind of a validation of these practices. The purpose was to looking at how populations can use these locally available knowledge and resource for the problem of which globally we are seeing. So one formulation, of course, I'm just skipping the many steps involved in identifying one formulation which community gave to us, about 5 medicinal plants, which we called as a TPMP74. And these medicinal plants are locally available, accessible, and community were known. And we standardized the formulation, preclinically tested, where we use these liver stage, hepatic stage model. I'm not going to the details of this methodology and what kind of techniques we used and all. I have a detailed presentation which we can see it later stages. But what we observed is these decoctions which we documented in Koraput district and other districts, these are able to inhibit the growth of parasites in the liver stage. Let's say the stage of parasites in the side zone and the merozoites kind of a stage, we can see the expression of these merozoites was delayed. And we observed the TC50, IC50 toxicity curves and make sure that the delay in liberation of the merozoites into the bloodstream. That's a one understanding we got, and we worked through one of the very well-known scientists in the field of malaria, Dr. Dominic Mazia, from the INSAM lab in France. We have a collaboration with them. So in their lab, they have tested these formulations and make sure that like how these formulations can really contributing. But there's a kind of an idea we got it. Later, we also tested in some of the mice model where we want to see that like how people are taking when they're healthy. So healthy mice we gave these decoctions and looking at how these hepatic forms or the blood stage forms are developed. So we observed that there is an interesting result in this also. The mice are protected for some of the extra additional days in producing about the blood stage forms. So and then we did a human field study after these two experiments. Again, we did a kind of a very small scale non-randomized studies in Koraput district, just to looking into the two adjacent villages, because very small villages in Kakarigma block in Koraput district, where we observed a significant reduction of malaria cases in those groups who have taken this decoction 2 days in a week, about 3 months, and the other group, which is also controlled, which is also without giving any other medicines, just following whatever the government norms, what are the government programs. So this was implemented in collaboration with NIMR, National Institute of Malaria Research, and TDU and other organizations. So in this, what we're trying to do is, it's not like, I understand there's a lot of limitations in these studies, but this is an indication what we got. These herbal medicines can contribute. Our idea is not to develop a new drug or something about the market or a product which company can produce and give. How to strengthen these practices which people are already using, and we make it a standardized formulation in our lab. We did all the quality control check, QC, and standardized with all the HPLC, fingerprinting to make sure about the batch-to-batch variations on what kind of preparations and all. It was freshly prepared decoctions, which was bottled and in the presence of doctors, we administered for local community with all the approvals of ethics committee and all the other committees. So this also got published. You can see about the results, what I mentioned about the other lab studies which we have done in collaboration with the ICM and with the other institutions like ICMR as well as NIMR, as well as with the in some lab in France. So we got these two interesting results, which I already showed the graph in them. And later, when I worked with these things, we also try to understand how community enable these practice, how community take these, and it's very important to build the confidence of these healers, those who are already giving these medicines. So this was a study which we did, and this is some of the experience as I mentioned. And this study has also got interesting results, and today we have some publications on these things. And overall, our approach was to show to the scientific community where how these traditional medicines are using and people are using, and how we need to go into the little more detailed studies, detailed understanding with the different approaches, and also look at whether they can really contribute. If they're able to contribute, how to enable the community and build the capacity of the communities as well as the local NGOs and CBOs to encourage them, whatever the practice they were doing. If we are able to get a scientific validation, how to continue into the later things. So currently, I can say some of these experiments. I'm not going to the details. I'm very sure. So this is the approach what TDO is looking. How other approach, a traditional medicine approach, can contribute in addressing to the local communities. Local communities can get benefit, which is much more easily accessible, affordable, and accessible to the community. So with this very brief presentation, I'll stop. If I have any questions, I'll be happy to take these questions. I'm very sorry for the rushing about the whole slides and all. I know understand the limitation of this time, what Dr. Nidhi mentioned. That's why I was little briefing the whole thing. So thank you very much for the organizers for this opportunity. Thank you.
Thank you so much, sir, for that insightful discussion about the efforts and the work that has been done at TDU. I'm sure many participants have comments. I request them to put in the chat box. Considering the time, I request Neha Kare, she is with us. She is working with Sangwari, an organization which is working in Sarguja district. and they are also seeing a lot of malaria cases recently. So I request her to please unmute and share her experiences. After that, we will take the open the meet for discussion, and for the remaining participants, unfortunately, we will have to take one more session, considering that this is a really vast topic. And then we can take their perspectives into the meeting.
Uh, thank you, Srinidhi and Yumita for this opportunity. Uh, I'm Neha and I work in Sarguja, which is the northern district in Chhattisgarh. I do not have anything to share. I do not have a presentation. I want to share the current scenario, just 2026 scenario of malaria in Sarguja district that we saw. In only We currently run three clinics in Sarguja district, and only one clinic, which is located deep in the forest, has recorded 56 cases of malaria in this year. And specifically, the prevalence of these cases is most commonly seen in the particularly vulnerable tribal group called Pahadi Korwa. And none of the patients that we saw had any kind of severe malaria, but their parasite count ranged from 2% to 8%. So, I'm not a public health physician, I'm not a public health expert, I'm a sure clinician, uh, primary health clinician. So, my questions to all of you as public health practitioners and experts is that. Uh, how do I look at this scenario when malaria cases arise in a most non-seasonal part? We expect the malaria to arise, or we expect the malaria cases rise during winter period, like early Diwali or something. But this particular time of malaria is extremely unusual according to my experience uh, from 2016 onwards. Uh, Also, uh, with sudden low burden, how come the mosquitoes are, or I mean, what is this kind of behavior of the vector, which is kind of resurging up, and when to expect, what to discern out of these unusual seasonal patterns, as well as uh, the disease pattern. That is it. I think the question. I just need some answers. That's. Thank you.
Thank you so much, Neha. Uh, that is the last presentation that we could take for this session. But considering the amount of presentation that we had, we we should have a discussion for at least the next 15 minutes. I request the participant to give a comment or opinion or any other question that you might have uh, with regards to today's discussion. Uh, Yogesh sir, could you please share your comments?
Okay, I mean, if I may, obviously, the fact that we are having this discussion on malaria in 2026 monsoons is perhaps because we have seen increasing number of reported malaria cases, as well as the some sort of impression from other places across many states. And surely we can say that that is the case with the states, those 10 states that we talked about, the northeastern states. I don't know, but so much. But for central Indian states like Chhattisgarh, Jharkhand, Orissa, um, Madhya Pradesh also, as well as parts of Telangana and Andhra Pradesh, as well as possibly Rajasthan, I'm told. So, and this is in the context of, if you know, many of you might know that there is a joint monitoring mission on malaria that is going to be happening very soon. In fact, starting 31st of August, which is going to be there in 4 states of the country, which are none of those are, actually high burden states. Except, sorry, there are 3 of them are not high burden, and one is certainly a high burden state, Orissa. The others are, I think, Rajasthan, Tamil Nadu, and I've forgotten which is a 4th state. But unlike you previously joined monitoring mission that happened, which all across the country, and the reason why this has happened is something for all of us to even ponder upon. That we what is this elimination strategy, and what are the pitfalls of this elimination strategy in a situation where then there are a number of many parts of the of central India at least, which is reporting a larger burden of cases. And as a colleague from from MGIMS was talking about, the number of cases in the last 4 years have increased. It's not a one-time spike in a month, in a year, and then it's persisted and in an incremental fashion since 2022. So and if I may very briefly say, an elimination strategy has many cons also. It's not just that it is always a good idea to do much more, and because it costs a lot of money for the state to do, and secondly, the surveillance pattern that you do is completely different. You start even investigating asymptomatic malaria cases, but you also start investigating border areas, migration that happen, because the objective is different from a control strategy, and individual cases become important. So obviously that is not a strategy that would work when the number of cases are too many, like in thousands, if I may say. So, and control strategy requires control measures also, like bed nets and things. And one of the continued policy nonsense that happens in any of these strategies is that you get the resources depending upon your API. Now, if your API is less than one, then you will not get bed nets for control, which begs the question: what determines the API? API also determines on the your surveillance methods. It's not just even if you reach an ABER of 10, that doesn't mean that you're able to capture all the correct cases, because the reporting is systemically underreporting has happens in the public system, and in any case they don't ensure that they get data from the private sector or from the informal sector or from the NGO sector. So I think we need to be all cognizant of the fact that the elimination strategy is something that we should question, if I may say, for areas that are having high burden. And otherwise, we are neither going to eliminate the disease, not even, and we might even in fact have a resurgence. And I fear at the moment that we might get into a situation of 1968 once again. When we were talking about the history of malaria control, the malaria bug is much smarter than us. um, uh, you know um, and yeah and so yeah, I would stop here to just share this worry about uh, having, in a sense, a policy paralysis about malaria. Over.
Yeah, sir, very true. Because the way all the districts are like put forward for elimination, it seems like some kind of an agenda.
Mm.
And WHO and the state program officers and independent experts from ICMR, they go as a team for verification of the documents. I mean, okay, it is a like a 1 week visit to that particular area, but then the districts are so prepared that they will take to only those places where they are very like polished and kept everything ready. So how do you actually decide on seeing everything painted and very nice, and then all the documents made fresh, to understand the history of the malaria that has been like really near elimination in those particular districts? So yeah, elimination strategy is really questionable. And WHO as a whole does not support the district level elimination as such. So even if WHO goes as a verification agency, but I mean, we are told not to sign on those kind of reports.
Yeah.
There is a question in this chat box by Pavni. There were no cases for 2 to 3 years, followed by a rise again. Could you please comment on what might be driving this trend? Uh, can the esteemed speakers will talk about this? Thank you.
So obviously, we did not do what we should have done when the cases were coming down. We let down our guard. If you remember, I mean, any one of us can comment upon in which was the last year that bed nets were distributed in Jharkhand or in or Chhattisgarh or in other states like Orissa, in across the state, and even if we assume that the API was calculated correctly, when were the bed nets distributed? In Chhattisgarh, they have not given it since 2019. I know from Jharkhand, they did not give it since 2021, or which someone said yesterday. And if you know this, that even in this year, 2026, there have been over 15,000 cases reported from one district called Kanker in Chhattisgarh, and East Singhbhum in Jharkhand has reported over 15,000 cases again. So we did not distribute bed nets. There is a supply chain for RD kits, and ACTs have broken. Many places have not received it for months together. People have lost the skill of doing the RD kit testing because the ashas were trained in many places, years ago. And if you don't do the test properly, you know that you can make a mess of it. And slide microscopy has gone out of the bin, out of the window. So, so it was, when we don't do things, then obviously the disease is going to come back. Whatever we achieved was very transient in a way. This the down the and so in fact the malaria decline was largely, inexplicable in a way, that happened from 2015 to 2022. But since 2022, we are doubling the number of cases every year, even if they are smaller than what we had in 1978.
And sir, another thing that is happening in the program now is now everything is decentralized for the state to procure,
Yeah,
like
yeah. So bed nets have to be
uh,
has to be procured by the states now,
state
and
only.
the
Yes,
states
yes.
don't have the capacity to procure. Forget
Hmm.
about the money. They don't even know how to know there is a global tender for bed nets. बेड नेट्स कहाँ से आएंगे अगर आपको हजारों में चाहिए, 10 ही हजार में चाहिए तो?
यस यस, वो भी है। और अभी तो मलेरिया मेडिसिन एंड आरडीटी किट्स भी मेरे ख्याल से अगले साल से तो हो ही जाएगा, दैट यू हैव टू प्रोक्योर इट ऑन योर ओन। एंड अनदर थिंग इज दैट ग्लोबल फंड इज गोइंग टू come to an end, so all these northeastern states and the seven JCO
Yeah, yeah,
states,
they'll all suffer. Yeah, yeah.
yeah, they are going to suffer very, very bad, and there has to be a resurgence, and we are not eliminating anything by 2030.
No, no.
This
In
is
any
my
case, if you know, all of
yes.
us should know that elimination strategy, even when the number of cases go down, the money that you require for an elimination strategy is much more than what you require for a control strategy, because your surveillance methods, each patient, each case being investigated, and looking at in asymptomatic cases, focusing on Vivex malaria, which is not really come down. All those strategies in elimination are so much more expensive to do. So, while our focus of public health should be first to mitigate the situation for the one that people should not die, and then should also not suffer complications which require hospitalization, and also improve fast. I think, yeah, this is, but who's going to question? Are you going to ask Cockroach Janta Party to question whether, elimination strategy, or the guys around in this meet call should be doing this? Why don't we all discuss it together and, question it? And I mean, our academics, I don't expect them to do things, they to question the state. But can people who are practicing, like all of us, can we, sort of raise our voice and raise it with whatever, question this, this insane strategy of elimination? Yeah.
I think Probir has left a comment in the chat box. Would you like to टॉप एज वेल एंड इवन मोहम्मद अनीश अंसारी जी, आपने केस को छुपाया जाए तो एलिमिनेशन की बात कैसे, इट्स अ वेरी इंपॉर्टेंट कमेंट फ्रॉम हिज साइड आल्सो. अनफॉर्चुनेटली वी कुड नॉट टेक एनी inputs from him. He has done a lot of work in malaria in Jharkhand, so I request them if they can share their experiences in a minute.
Acha, my comment is there. Just look at the comment because very strange that the nets have not been distributed in Chhattisgarh. Let Anish speak. I think Anish can tell you a lot of things.
सभी को जोहार सर। मैं अनीश पाकुड़ से, झारखंड पाकुड़। उतनी एक्सपीरियंस नहीं है, बट जितना हमने किया है कुछ हम बता दें कि अभी जैसे मॉस्किटो नेट की जो बात आ रही है, हमने एक अभियान चलाया था कि जो कुछ समय हमने कालाजार पे काम किया है, अवेयरनेस पे। तो मॉस्किटो नेट डिस्ट्रीब्यूट हो जाते हैं, बट सो एज इट इज उन लोग बक्से पे कहीं पे रख देते हैं, वो उसको खोलते नहीं है, यूज नहीं करते। यहाँ पे अवेयरनेस की कमी है। तो हमने एक अभियान चलाया था कि एसएलपीएस की एसएचजी के द्वारा कि आप लोग ऐसा करिए कि एक दिन फिक्स करिए और सभी दीदी अपने अपने घर से मॉस्किटो नेट को निकाल लीजिए, क्योंकि उसमें जो सिलाई वगैरह खुला हुआ रहता है, फटे रहते हैं। तो वो सुई और धागा लेकर के बैठ जाए आप लोग और उसको सिलाई करके उसको यूज करें। तो इस बहाने क्या हुआ कि बहुत सारे ऐसे मॉस्किटो नेट जो निकाले, जो जो डिस्ट्रीब्यूट किया गया था, उनके हाथ में दिए गए थे, एज इट इज उसका फोल्ड ही पड़ा हुआ था, यूज ही नहीं किए थे, जिसका हमने स्टेट डिस्ट्रिक्ट को भी रिपोर्ट किया, दिखाया था। तो कहने का मतलब यहाँ पे क्या है कि जो मॉस्किटो नेट दिए जाते हैं उसको कैसे यूज करना है। उसको बॉडी में टच होने से थोड़ी सी जलन टाइप की होती है, तो उसको खुले में और छांव में खोल के रखना है कुछ समय। ये सब कहने का मतलब यहाँ अवेयरनेस की कमी है। अगर डिस्ट्रीब्यूट करते हैं तो यूज नहीं होता है। उसको जा करके मछली जाल बना करके कहीं मछली पकड़ने चले जाते हैं, या उसमें पत्ते वगैरह, सूखे पत्ते वगैरह बांध करके उसको रखते हैं ताकि उसको जलावन उसको ये करे। तो ये चीज है। दूसरा क्या है कि मेडिसिन की उपलब्धता नहीं रहती है, जिस कारण डेथ हो जाते हैं, या तो वो बहुत मुश्किल में पड़ जाते हैं। क्या होता है कि अभी कुछ समय पहले हुआ था क्या कि जैसे कालाजार का मेडिसिन उपलब्ध नहीं था। अब वो क्या है, दूसरे डिस्ट्रिक्ट से मांगो, यहाँ पे नहीं है। अच्छा, जैसे पीकेडीएल केस का दवाई नहीं है। पीकेडीएल कंफर्म है, लेकिन दवाई नहीं है। दवाई नहीं के कारण क्या, रोके रहो अभी उसको जब तक दवा ना आ जाए। तो इससे क्या है, केस तो बढ़ता जाएगा। और इसके बाद फिर और एक पॉइंट है कि रोड कनेक्टिविटी, हेल्थ सब सेंटर, जैसे एग्जांपल लिट्टीपाड़ा और अमड़ापाड़ा, ये मलेरिया कालाजार का बहुत ही गढ़ है। वहां पे क्या है कि हेल्थ सब सेंटर दूर में है, वहाँ स्टाफ रहते नहीं है। वैक्सीनेशन का सप्ताह में 2 दिन वैक्सीनेशन, वो अपना वैक्सीनेशन में चले गए। अगर किसी को बुखार है तो हेल्थ सब सेंटर जाएंगे दवा लेने के लिए, तो वो मिलेंगे नहीं कोई। तो फिर क्या होता है, वो फिर जाकर के झोला छाप वगैरह से लेकर के उनको बाध्य होकर के उनसे लेना पड़ता है दवाई। और उनके पास क्या होता है कि जो डोज होता है, डोज नहीं दे पाते हैं। वो कुछ हमने सिंगारसी साइड में देखा था, वो फैल्सीपेरम केस के लिए प्राइमाक्विन का कभी यूज ही नहीं किए थे। तो ये सब चीजें हैं। स्टाफ रहना नहीं चाहते हैं रात में, सिक्योरिटी। तो वैसे स्टाफ को क्यों लेते हैं जो सिक्योरिटी का भय इस कारण हेल्थ सब सेंटर में जाते नहीं है। हमें नहीं रुकना है वहां पे, 3 बजा वहां पे भाग जाते हैं वहां से। तो फिर जब भी बीमारी बढ़ती है रात के टाइम में बढ़ती है, तो फिर क्या होता है कि वो नहीं रहने से गांव के लोग वो दवा भी नहीं ले पाते हैं। ये कुछ चंद बातें हैं जिसको जो है ये, और जितने भी अवेयरनेस के जितने भी वीडियोज वगैरह बनते हैं या दिखाने के लिए, अक्सर हाँ ज्यादा होता है हिंदी में। इधर हमने कुछ संथाली वगैरह में करवाया था कालाजार का, जाकर के कुछ उसमें इम्प्रूवमेंट हुआ और स्प्रे वगैरह लेने लगे थे, मड प्लास्टिंग वगैरह लेकर के। जो इसके बाद फिर जो है अच्छी तरह से लेना, ये सब चीजें थी जो हमारा एक्सपीरियंस है। ये चंद बातें थी। केस को छिपाया जाता है क्योंकि हमें सरकार का भय है। सरकार हमें क्या कहेगी, हमारा जो है इतना टारगेट है, इस टाइम में हमको पूरा करना है। तो क्या होता है, इस ब्लॉक का केस को उस ब्लॉक में डाल देना, उस ब्लॉक का उसमें डाल देना, छिपा के रखना। तो कहने का मतलब, अगर हमारे शरीर में कैंसर का कहीं है, छिपा के रखेंगे तो एक दिन ब्लास्ट होगा, लास्ट में खत्म हो जाएगा। तो ये चीजें हैं जो कमियां दिखती हैं। थैंक यू।
थैंक यू अनिश जी। अ, कोई और है पार्टिसिपेंट जो शेयर करना चाहे तो प्लीज अनम्यूट करिए और शेयर करिए। अ, गजानन, आपको कुछ शेयर करना है?
जी हाँ। तो ये जो सेशन था, मतलब ये एक्सपेक्टेशन था कि हम शुरू में ब्रीफली पॉलिसी को देखेंगे कि हिस्टोरिकली क्या रहा है और अभी क्या है, एंड देन लोगों से सुनेंगे कि अभी ग्राउंड में क्या हो रहा है, ताकि ये समझ में आए कि ये रिसर्जेंस हो क्यों रहा है। मुझे जो लगता है कि 2022 से जो केसेस बढ़ना चालू हुआ, तो उसको हमने एक साइक्लिकल ट्रेंड है ये सोच के उसको हमने निग्लेक्ट कर दिया। जैसे अभी जो ग्राफ्स में भी दिख रहा था कि 2022 से केसेस तो बढ़ रहे थे, तो अभी हम चौथे साल में है जब हम ब्लास्ट ऑफ केसेस देख रहे हैं। तो पिछले 4 साल में, अब 22 को तो ठीक है, हम सोच सकते हैं कि कोविड था, लेकिन उसके बाद भी जब केसेस बढ़ते रहे, तो जब ज्यादा केसेस बढ़ते हैं तभी हमको मलेरिया का याद आता है, जबकि मलेरिया में ये हिस्ट्री भी है कि रिसर्जेंस हुआ है, हमने स्ट्रेटेजी चेंज की है, तो इसलिए हिस्ट्री को जानने की कोशिश कर रहे थे कि तब क्या हुआ था, तब हमने क्या स्ट्रेटेजी चेंज की थी जिससे रिसर्जेंस हुआ, और उससे आज के समय में क्या सीख सकते हैं। जैसे एक जो सर ने बताया कि हमें कंट्रोल स्ट्रेटेजी पे जल्दी शिफ्ट होना चाहिए। तो और भी चीजें, जैसे मुझे लगता है कि इस साल छत्तीसगढ़ की बात करूं तो नॉन फॉरेस्ट विलेजेस में भी मलेरिया आ रहा है, तो और हमेशा हम बोलते हैं कि फाल्सीफेरम या जो प्लाज्मोडियम का रिजर्वायर है ये फॉरेस्ट है, लेकिन फिर नॉन फॉरेस्ट में क्यों आ रहा है? क्या ये डिस्ट्रीब्यूट हो गया इतने जल्दी? अभी तो चालू भी नहीं हुआ, इतने जल्दी क्या नॉन फॉरेस्ट में कैसे चला गया? या हमारा रिजर्वायर शिफ्ट तो नहीं हो रहा है कि अर्बन में भी अभी मैंने देखी कि केसेस बढ़े हुए हैं, डेथ जरूर घटे हैं, तो फिर क्या ऐसे हो रहा है कि ये रिजर्वायर चेंज हो गया है विद द क्लाइमेट चेंज? क्या क्या हमें अलग से फिर स्ट्रेटेजी सोचनी पड़ेगी कि हमेशा हम सोचते हैं कि फॉरेस्ट विलेजेस में ही इसको कंटेनमेंट करें, हम नॉन फॉरेस्ट तक स्प्रेड ना होने दें, जबकि इस साल पहले ही महीने में नॉन फॉरेस्ट विलेजेस में ये देखने को मिल रहा है। अब जो मैं ये भी देख रहा था कि एंटी लार्वल, मतलब एंटी वेक्टर मेजर्स जो है, जिसके ऊपर 1970 के बाद मेजोरिटी जो फोकस रहा है पब्लिक हेल्थ में, ये हमारा वेक्टर कंट्रोल पे रहा है। इसमें दो मेन स्ट्रेटजीज है, इंसेक्टिसाइड ट्रीटेड बेड नेट्स और इंडोर रेसिडुअल स्प्रे जो ITN एंड IRS। तो इसके बियॉन्ड हम अभी गए नहीं है। वैक्सीन की हम बात करते हैं लेकिन अभी तो वो रिसर्च फेज में है, या जैसे ये प्रोफाइलेक्टिक डिकॉक्शन, ये सब रिसर्च फेज वाली चीज है। तो इसके ऊपर रैंडमाइज कंट्रोल ट्रायल भी हुए हैं, उसमें क्लियर कर रिकमेंडेशन है कि हमारे पास रेफरेंस लैब होना चाहिए, वहां पे रेजिस्टेंस टेस्टिंग हमने करने की जरूरत है। अलग अलग वेक्टर्स है, क्या ये बिहेवियर चेंज हो गया है? क्या जो स्लाइड्स और डेटा हम दिखा रहे हैं ये कितना पुराना है? क्या क्लाइमेट चेंज के बाद इसमें कुछ चेंज आया है? क्या क्या हम इसको स्टडी कर रहे हैं क्या? तो ऐसे सारे सवाल मेरे मन में है, और मुझे लग रहा है ये एक शिफ्ट दिख रहा है एपिडेमियोलॉजी में। तो इसको हमें रिविजिट करने की जरूरत है, और इसके लिए हमें लैब लेवल पे भी एडवोकेट करना चाहिए। कंट्रोल स्ट्रेटेजीज ऑब्वियसली ग्राउंड लेवल पे करना जरूरी ही है। और जो इंसेक्टिसाइड ट्रीटेड बेड नेट्स में भी मैं देख रहा था पायरेथ्रॉइड ट्रीटेड बेड नेट, और दूसरा एक और बेड नेट है जिसके दोनों के रैंडमाइज कंट्रोल ट्रायल हुए हैं। और उसमें फिर ये बोला हुआ है कि जहाँ पे लो इंडेमिक रीजन है, वहाँ पे पायरेथ्रॉइड ओनली नेट्स जो है इफेक्टिव है। और ये भी जो डॉक्यूमेंटेड है कि बहुत सारा पैसा इसमें वेस्ट हो गया है, जो बहुत यूजफुल नहीं है। बहुत सारे मतलब नॉन कॉस्ट इफेक्टिव मेजर्स पे भी पैसा खर्च हो गया। तो शायद अभी डिस्कशन से भी यही चीज लग रहा है कि हमें ये चीज पता है, लेकिन फिर हम उसी को इम्प्लीमेंट कर रहे हैं। जब हमको पता है कि नॉन कॉस्ट इफेक्टिव मेजर्स पे पैसा खर्च हो गया है मलेरिया का, और अभी ग्लोबल फंड नहीं है तो पैसा कम है, और हमने मतलब फिर उसको कैसे यूज करना चाहिए, ये भी एक सवाल है। फिर एक है कि जब हमने स्ट्रैटेजी को डिसेंट्रलाइज किया, तो क्या हमने कैपेसिटी बिल्डिंग किया? क्या जो भी डिस्ट्रिक्ट्स है उनको कौन सपोर्ट कर रहा है? क्या जितना कैपेसिटी सेंट्रल मैनेजमेंट में था उतना ही कैपेसिटी डिसेंट्रलाइज मैनेजमेंट में दिया गया है क्या? वो किसके हाथ में दिया गया है? प्लेसेस जो वैकेंसीज है उसका क्या रोल है? अभी जैसे हमने देखा कि सब सेंटर्स नहीं है। हमने ये भी सीखा है कि सीपीएचसी स्ट्रांग होना एक बहुत जरूरी है मलेरिया डेथ्स को कम करने के लिए, या मतलब इन एपिडेमिक कोविड में भी ये सीखा है। तो ये सब लर्निंग्स क्या हम भूल जाते हैं? मतलब क्यों भूल जाते हैं? इसकी मेमोरी रखने के लिए क्या सिस्टम्स होने चाहिए? मुझे लगता है ये भी कुछ चीजें हैं जो शायद हमें अभी, जैसे अगर जॉइंट मॉनिटरिंग मिशन आ रहा है तो इनके सामने ये बातें रखने की जरूरत है। और
थैंक यू गजानन। आज हमने झारखंड के कई दोस्तों से और उड़ीसा से हमने शायद बातें नहीं सुन पाए थे, और कुछ लोगों से हमने बातें सुनी है, जैसे बिलासपुर की भी बात हम लोग अच्छे से नहीं सुन पाए, उनके भी अनुभव कुछ रहे हैं मलेरिया मैनेजमेंट को लेकर के। तो क्या हम एक और सेशन इस पे ले, जिसमें हम इन लोगों के अनुभव साझा कर पाए और कुछ इसके ऊपर डिस्कशन कर पाए? और गजानन, व्हाट डू यू थिंक अबाउट दिस, लाइक डू वी नीड टू टेक वन मोर सेशन?
हाँ हाँ, मुझे लगता है अभी प्रफुल्ल भैया भी बात करने वाले थे, उनको भी नहीं मौका मिला है, और बाकी लोग भी। तो मुझे लगता है अभी हमने पॉलिसी पढ़ा और कुछ कुछ जगह के अनुभव सुने। मुझे लगता है क्या क्या काम किया और क्या काम नहीं किया, दोनों पे बात होनी चाहिए, ताकि हम एक दूसरे से सीखें। मतलब मैं तो इन फेवर हूँ कि हमें अगले गुरुवार और बैठना चाहिए और इसके ऊपर डिस्कस करना चाहिए। बस एक चीज है कि हम चीजें रिपीट ना करें। शायद अगर श्रीनिधि, अगर और बाकी सबको भी लगता है तो स्लाइड्स हम पहले से रिव्यू करें, थोड़े से ट्रिम करें, तो फिर हम टाइम जो है थोड़ा सा बचा पाएंगे, और उसको इफेक्टिवली मतलब यूटिलाइज कर पाएंगे, ताकि जितने भी लोग अटेंड कर रहे हैं सब लोग अपना डिनर छोड़ के कर रहे हैं, तो उनके लिए भी वो यूजफुल होना चाहिए। बस इतना मेरा एक कमेंट।
ओके, थैंक यू। इसी के साथ हम लोग इस सेशन को एंड करते हैं। थैंक यू सो मच एवरीवन फॉर ज्वाइनिंग एंड शेयरिंग योर एक्सपीरियंसेस। It was a great learning opportunity, and this video will be soon uploaded on YouTube. And we will announce the next session soon. Thank you so much, and good night.
थैंक यू।
Thank you.
थैंक यू सर।
Yeah.